Hello everybody. It gives me a great pleasure to share in such a prestigious CME event, which is the review course organized by Egyptian Society of Cardiology. I hope that my presentation give the knowledge which you need to know about the diagnosis and ischemic and bleeding risk stratification in acute coronary syndrome. Fortunately, we had in the last few weeks the 2020 European Society of Cardiology guidelines for the management of acute coronary syndrome in patients presenting without persistent segment elevations. There is some changes from the previous guidelines, which we will show you in the coming slides. First of all, we have to know that the acute coronary syndrome is one of the major emergencies in the cardiology, and we have all to know how to diagnose, how to use the investigation tools, and how to tailor our treatment evidence-based in order to get the better outcome for those patients. The clinical presentation first is the first step in diagnosing the non-segment elevation ACS. The prolonged more than 20-minute angina being at rest is one of the characters. The new onset de novo angina class 2 or 3, the Canadian Cardiovascular Society classification, is also another point. The recent destabilization of previously stable angina with at least Canadian Cardiovascular Society class 3 angina characteristics, which named crescendo angina or the post-myocardial angina. Those all the forms of the non-segment elevation ACS. Another important station is the ECG. The resting 12-lead ECG is the first-line diagnostic tool, which should be done as early as we can after the patient presentation. Characteristic abnormalities include ST segment depression, transient segment elevation, and T-wave changes. If the standard leads are inconclusive, which is a very important point, and the patient has signs or symptoms suggesting of ongoing myocardial ischemia, we have to use additional leads. We have to record additional leads because left circumflex artery occlusion or right ventricular myocardial infarction may be detected only in V7 to V9, which are the posterior leads, and V3R and V4R, which are the right leads. In patients with suggestive signs and symptoms, the finding of persistent segment elevations indicates a segment elevation myocardial infarction, which of course, as we all know, mandates immediate reperfusion. Those are some patterns of the ECG we have to know. Of course, if we have a normal ECG, this signifies of no clue. If we have isolated T-wave inversion, only mild impaired prognosis. If we have another pattern like ST segment depression, more severe ischemia, of course. If there is transient segment elevation, which is much more dangerous, only mild impaired prognosis. If we have what's called the De Winter STT, this means approximal LED occlusion or severe stenosis. What's called also the Wellen sign, as you see here in the ECG, this indicates proximal LED occlusion, also severe stenosis. If we have a resting U-wave inversion, this means occlusion or severe stenosis of the left main artery or LED. And finally, one of the poorest prognosis, those with low QRS voltage. Another important station is the biomarkers. Biomarkers complement clinical assessment and 12-lead ECG in diagnosis, risk stratification, and treatment of patients with suspected non-segment elevation acute coronary syndrome. And as we all know, measurement of biomarker of cardiomyocyte injury, preferably high sensitivity cardiac troponin, and the recent guideline is stressing on the high sensitivity cardiac troponin, which is mandatory in all patients with suspected non-segment elevation acute coronary syndrome. This is a very important table which shows us the clinical implication of high sensitivity cardiac troponin assay. Compared with the standard cardiac troponin assay, it has a higher negative predictive value for acute myocardial infarction. Of course, it reduced the troponin blind interval, which is very important, leading to earlier detection of myocardial infarction. result in about 4% absolute and 20% relative increases in the detection of type 1 myocardial infarction and a corresponding decrease in the diagnosis of unstable angina. They are associated with a twofold increase in detection of type 2 myocardial infarction, and those are the importance of the high sensitivity troponin in comparison to the conventional one. The condition other than acute type 1 myocardial infarction associated with cardiomyocyte injury, we have to know because we sometimes face a elevation of cardiac troponin in some situation which it is not myocardial infarction. The tachyarrhythmias, the heart failure, the hypertensive emergencies, some critical illnesses like shock, sepsis, and burns, myocarditis, Takotsubo cardiomyopathy, and also severe valvular heart disease like aortic stenosis, aortic dissection, and we have not to forget the pulmonary embolism and pulmonary hypertension, also in patients with renal dysfunction and associated with cardiac disease, acute neurological event like stroke and subarachnoid hemorrhage. All those conditions may be associated with elevations of troponin. The cardiac contusion or cardiac procedure like CABG, PCI, ablation, pacing, cardioversion, endomyocardial biopsy, sometimes also it is accompanied by elevation of cardiac troponin. Also the hypo and the hyperparathyroidism, infiltrative disease like amyloidosis, hemochromatosis, sarcoidosis, and scleroderma. Myocardial drug toxicity or poisoning also can be associated with elevated cardiac troponin. And finally, the extreme endurance efforts like rhabdomyolysis can be also associated with cardiac troponin elevation. This is a very important figure from the latest guideline which a few weeks released, which tell us how the diagnosis is dependent upon the four items, which is very important. The first is the clinical setting, symptoms and vital signs. And as you see here, the distribution of pain, the distribution of the clinical situation and vital signs, taking us from low likelihood of myocardial infarction to high likelihood of myocardial infarction. Second is the ECG. And of course, also the normal ECG, the S-segment depression, the more S-segment depression, and the S-segment elevation, taking us also from the low likelihood to high likelihood for acute coronary syndrome and non-segment elevation myocardial infarction. Also the troponin level at the baseline and the troponin level after 1 hour or within hour, 2 or 3 hours also are very important to take us from the low likelihood to high likelihood of acute coronary syndrome. And of course, by using those clinical criteria, we can rule out MI because it is non-cardiac. We can also observe them because they will proven to be unstable angina or other cardiac condition, and we can rule in myocardial infarction if we have a high likelihood by those clinical criteria to be non-segment elevation myocardial infarction or S-segment elevation myocardial infarction. Again here, the suspected non-segment elevation acute coronary syndrome, the guidelines confirming the use of the baseline level, which if it is very low or if the change after 1 hour, which is the new recommendation to do it after 1 hour, 0 to 1, if it is still low, this is will rule out the condition of acute coronary syndrome, and the patient should be discharged with optional stress testing or CT or even angiography if the patient is high risk or if it is proven to have a stress testing positivity. If we have a mid-range of troponin, we have to observe the patient doing echocardiography to rule in the patient to CCU for doing angiography and echocardiography, or to rule out him for discharge and optional testing. Sometimes the patient also can be kept on the ward for more tests like the CT stress testing, and if they are positive, we can push him to the angiography. So this figure is clarified to us how to use the baseline troponin and the change in the troponin level in after 1 hour to rule in or to rule out the diagnosis of non-segment elevation acute coronary syndrome. And here we come to the recommendations by the latest guideline that it is beyond its diagnostic rule. It is recommended to measure the high sensitive troponin serially for the estimation of prognosis, which is class 1 level of evidence B. Also, a new recommendation here to use the PMP or NT-proPMP plasma concentration should be considered to gain more prognostic information with class 2A level of evidence B recommendation. And an important point here also that the measurement of additional biomarkers like mid-regional pro-A-type natriuretic peptide, high sensitivity C-reactive protein, mid-regional pro-adrenomyelin or copaptin are not recommended for the routine risk of prognosis measured as class 3 level of evidence B. What about the non-invasive imaging? We have to know that the echocardiography is a very important station in diagnosing the non-segment elevation acute coronary syndrome, and it should be routinely available in emergency room and chest pain units and performed and interpreted by trained physician, which is also another important tip here for all patients during the hospitalization of non-segment elevation acute coronary syndrome. The imaging modality is useful to identify abnormalities suggestive of myocardial ischemia or necrosis in the form of wall motion abnormalities like segmental hypokinesia or even akinesia. Not only, but moreover, echocardiography can help in detecting alternative pathologies associated with chest pain, such as acute aortic dissection, pericardial effusion, aortic valve stenosis, hypertrophic cardiomyopathy, or right ventricular dilatation, which is suggestive of acute pulmonary embolism. So we can see here how the echocardiography is important station in diagnosing the non-segment elevation acute coronary syndrome and also to detect other differential diagnoses. In patients without ischemic changes on 12-lead ECG and negative cardiac troponin who are free of chest pain for several hours, here we have another important station, which is the stress imaging can be performed during admission or shortly after discharge. And we have to know here that the stress imaging is preferred over exercise test due to its greater diagnostic accuracy. Another diagnostic modality which is penetrating the investigation tools now with a very important sensitivity and specificity, the cardiac magnetic resonance can assess both perfusion and wall motion abnormalities, and patients presenting with acute chest pain with normal stress CMR have an excellent short and mid-term prognosis. So by using the CMR, we can also detect the short and mid-term prognosis for some subsets of the patients. What about the anatomical evaluation? We have now a new tool, which is the multi-detector CT, allowed for visualization of the coronary arteries, and also there is an upgrade for its use in the non-segment elevation ACS. A meta-analysis of 9 studies of about 1,300 patients has reported overall high negative predictive value to exclude acute coronary syndrome, an excellent outcome in patients presenting to the emergency department with low to intermediate pretest probability. So for those patients with low intermediate pretest probability, it is very excellent to use the multi-detector CT to rule in and rule out their acute coronary syndrome status. The differential diagnosis here of acute coronary syndrome in the setting of acute chest pain, we have a long list of problems that can mimic the acute coronary syndrome, starting from myocarditis, tachyarrhythmias, acute heart failure, hypertensive emergencies, aortic valve stenosis, Takotsubo cardiomyopathy, and even coronary spasm, also the cardiac trauma. We cannot forget the pulmonary embolism, the pneumothorax, the severe bronchitis and pneumonia, and the pleurisy. Also, one of the major emergency, which is the aortic dissection, we cannot neglect, and we have to search clinically very well because it is one of the medical emergencies. Symptomatic aortic aneurysm, stroke, gastrointestinal esophagitis, reflux or spasm. Also, the peptic ulcer and pancreatitis, cholecystitis can mimic the chest pain of acute coronary syndrome. We have also some of the orthopedic problems, which mimics the cardiac chest pain, musculoskeletal disorders, chest trauma, muscle inflammation, chondritis, cervical spine pathologies. Finally, we have not to forget the anxiety disorders. The anxiety disorders, which in most of patients mimic the acute chest pain of acute coronary syndrome, also the herpes zoster, and sometimes anemia. By knowing all those factors, we can put in our mind how to exclude the non-cardiac causes of ACS very probably. Ischemic risk assessment in non-segment elevation ACS, quantitative assessment of ischemic risk by means of a score is superior to the clinical assessment alone. As we all know, we have an important score, which is the GRACE risk score, provide the most accurate stratification of risk both on admission and at discharge. Upon this risk, we can plan our management. We can also know the prognosis for the patient. But in the last guidelines, there is a downgrade for the GRACE risk score from 1A to 2A, because that the Australian GRACE risk score intervention study, which is AGRIS, failed to demonstrate any add-on value, especially for the guideline-directed treatment with routine implementation of the GRACE risk score. GRACE risk score is still there, but downgraded, still important, but downgraded. We have to use it. And this is how to calculate the GRACE risk score for in-hospital mortality. Some very simple variables like age. For example, if the patient's from 40 to 49, he will take 25 points. And we have also to consider the heart rate from less than 50 and up to more than 200 with points for every heartbeats. For example, for those patients with 90 to 109, he will take 15 points. Also, we have to consider the systolic blood pressure from lower than 80 to more than 200 with different degree of points, as we mentioned before. Also, the initial serum creatinine we have to consider, and the clip class of his chest pain, the cardiac arrest at admission, which takes 39 points, elevated cardiac markers take 14 points, and the transient segmental deviation take 28 points. Simple criteria, simple calculation, which help us in tailoring our management strategy, and it will give us also an idea about the prognosis of these patients. If we have a look here to the interpretation of the GRACE risk score for in-hospital mortality, the score less than 60 means less than 0.2% probability of in-hospital mortality. But if we have a score of more than 140, we can get about 3.9% probability of in-hospital mortality if it is 150 score. It cannot go without mentioning also the bleeding risk assessment, because as we all know, the bleeding risk by itself is also an ischemic risk. So we have to make a bleeding risk assessment on those patients with acute coronary syndrome. Major bleeding events are associated with increased mortality in non-segment elevation ACS. Bleeding risk score have been developed from registry or trial cohorts in setting of ACS and PCI. We have a very important risk score, which is the Crusade bleeding risk score, and it was developed from a cohort of more than 71,000 non-segment elevation acute coronary syndrome patients, and further even validated for more than 17,000 patients from the same registry. In the Crusade bleeding risk score, we considered the baseline patient characteristics, the gender, the history of diabetes, the history of peripheral vascular disease or stroke. Also, a simple points we can get from the history. Admission clinical variables like heart rate, systolic blood pressure, and signs of heart failure. All these clinical points we can get easily during clinical examination. And the admission laboratory values by hematocrit, calculated creatinine clearance. It is also important for Crusade bleeding risk score calculation. The acute catheterization and urgent intervention triage strategy. Acute bleeding risk score is another important risk score, which is derived from a pooled cohort of more than 17,000 patients with ACS recruited in the acute and harmonizing outcome with revascularization and stents in the acute myocardial infarction, which is the Horizon MI trials. We have 6 independent baseline predictors: the gender, the female gender, the advanced age, the elevated serum creatinine, the white blood cell count, and the anemia. Those are very important predictors in the acute trial for the bleeding risk assessment. By knowing those predictors, we can tailor our management for using the unfractionated heparin and glycoprotein 2p3A inhibitor rather than bivlorudin alone if we are recognizing the acute bleeding risk score. The risk score identified patient at increased risk for non-CABG related major bleeds at 30 days and subsequent 1-year mortality. However, it has not been validated in an independent cohort. No risk calculator is valuable and model performance for the risk score is modest. Changes in interventional practice such as increasing use of radial access for those with high bleeding risk, reduction in the dose of unfractionated heparin, use of bivlorudin, diminished use of GB2B3 inhibitors, and administration of more effective inhibitor for the platelet adenosine ADP receptor B2Y12 inhibitor may all modify the predictive value of the risk scores, as you know. Ischemic and the bleeding risk needs to be weighed in the individual patients. We have to make a balance between the ischemic and bleeding risk when we are tailoring our medication, although many of the predictors of the ischemic events are also associated with the bleeding complications. Overall, Crochet and acuity scores have reasonable predictive value for the major bleeding in acute coronary syndrome patients undergoing coronary angiography, with the Crochet found to be the most discriminatory. So we had to depend on Crochet as a bleeding risk score for assessing our patient with non-segment elevation acute coronary syndrome, either treated medically or if the patient pushed to the cath lab for coronary angiography and PCI. Those are the major and minor criteria for high bleeding risk according to the academic research consortium for high bleeding risk at the time of percutaneous coronary intervention. The major criteria are anticipated use of long-term oral anticoagulation, which is very important to know, severe or end-stage chronic kidney disease with eGFR less than 30, if the hemoglobin is less than 11, if there is spontaneous bleeding require hospitalization and all transfusion in the past 6 months, moderate and severe baseline thrombocytopenia platelet less than 100, chronic bleeding diathesis, liver cirrhosis and portal hypertension, acute malignancy, previous spontaneous intracranial hemorrhage, previous traumatic intracranial hemorrhage at the past 12 months, presence of brain arterial multivenous malformation, moderate or severe ischemic stroke within the past 6 months, recent major surgery or major trauma within the 30 days prior to PCI, non-deferrable major surgery on that. Those are the major criteria for high bleeding risk. What about the minor ones? Age more than 75, moderate CKD from 30 to 60, hemoglobin from 11 to 30, spontaneous bleeding requiring hospitalization, chronic use of oral non-steroidal anti-inflammatory drug or steroids. Those are minor criteria for high bleeding risk. What's new in this guideline also is to use the integrated ischemic and the bleeding risk, because sometimes we need to maximize the ischemic protection and minimize the bleeding risk in individual patient. The specific risk score have been developed for patient on DAPT following PCI, because sometimes we would like to keep the patient for a prolonged period on DAPT. Sometimes we need also to shorten the duration of DAPT. This should be based on integrated and ischemic and bleeding risk score, which is the precise depth. The precise depth of more than 25 prolonged depth was associated with no ischemic benefit but a large bleeding risk. Conversely, longer treatment in patients with high bleeding risk with precise depth score less than 25 was associated with no increase in bleeding and significant reduction on composite ischemic endpoints of MI. So by knowing the depth a precise depth more than 25 or less than 25, we can tailor our depth duration for those patients to reduce bleeding and also to reduce the ischemic events. Scores to risk stratify. The guidelines told us that the GRACE risk score model should be considered for estimating prognosis, and as I said, it is downgraded to 2A. The use of risk score designed to evaluate the benefits and risk of different depth duration may be considered with 2P recommendation. The estimation of the bleeding risk, as I mentioned, the use of scores may be considered in patients undergoing coronary angiography with a 2B level of evidence B recommendation. Finally, I will come to the new recommendation and the old recommendation needed for the diagnosis, risk stratification, imaging, and rhythm monitoring in patients with suspected non-segment elevation acute coronary syndrome. It is recommended to base diagnosis and initial short-term risk stratification on a combination of clinical history, symptoms, vital signs, other physical findings, ECG, laboratory results, including the very important biomarker, which is the high-sensitive troponin. This is class 1 recommendation level of evidence A. It is also recommended to measure the cardiac troponin with high-sensitivity assay immediately after admission, which is called the zero time, and obtain the result within 60 minutes of blood sampling, and this is also a new recommendation with class 1 level of evidence B. It goes without saying the importance of the 12-lead ECG within the 10 minutes after first medical contact and to have to be immediately interpreted by an experienced physician with a class 1 recommendation. It is recommended to obtain an additional 12-lead ECG in case of recurrent symptom or diagnostic uncertainty. It means that we have to repeat the ECG if we still uncertain about the diagnosis of ACS. The ESC 0 hour to 1 hour algorithm with blood sampling at 0 and 1, it is now recommended as class 1 recommendation when this algorithm is available. Additional testing after 3 hours is recommended if the first 2 cardiac troponin measurement 0-1 are not conclusive and the clinical condition is still suggestive of ACS. Still also the 0-3 is a class 1 indication. As an alternative to 0 hour, 1 hour algorithm, we can use in some centers the ESC 0 hour, 2 hours algorithm with a class 1 recommendation level of evidence B. We have not to forget, as I mentioned before, the additional ECG leads because sometimes we miss the diagnosis of ACS because we are not doing the additional ECG leads, which is the V3R, V4R for right ventricular infarction, V7, V9 for the posterior infarction are recommended if ongoing ischemia is suspected when standard leads are inconclusive. As an alternative to the ESC 01 algorithm, a rapid rule out and a rule in protocol with sampling at 0 and 3 hours can be used with a recommendation of 2A level of evidence P. And I'd like to confirm again that the routine use of additional biomarkers like copeptin gives us no benefits where it will take the class 3 level of evidence B recommendation. In patient presenting with a cardiac arrest or hemodynamic instability of presumed cardiovascular origin, echocardiography is recommended and should be performed by trained physician immediately following the 12-lead ECG. And as I mentioned before, the bedside echocardiography should be there in every emergency room and chest pain unit to diagnose the acute coronary, to help in diagnosis acute coronary syndrome. In patient with no recurrent chest pain, normal ECG finding and normal levels of cardiac troponin, preferably high sensitive protein, but still with suspected ACS, a non-invasive stress test, preferably with imaging for inducible ischemia or CT, which is upgraded to class 1 recommendation, is mandated before deciding on an invasive approach. So here we can see the preference of stress imaging and CT before mandating invasive approach. Also, echocardiography is recommended to evaluate the regional and global LV function and to rule in differential diagnosis. As I mentioned before, the CT is recommended as an alternative to invasive coronary angiography to exclude ACS when there is low to intermediate likelihood. For those patients with low and intermediate likelihood, we have a class 1 level of evidence A recommendation to use the CT. Another important sector, it is the monitoring of the rhythm. The continuous rhythm monitoring is recommended until the diagnosis of nestomy has been established or ruled out with a class 1 recommendation. We have to keep the patient with a class 1 recommendation for 24 hours, either during the CCU stay or if he is pushed to the PCI to monitor his rhythm. So the 24 hours is an important period to follow up and to monitor the patient for his rhythm. Finally, my take-home messages, I'd like to confirm about the use of high sensitivity troponin. The algorithm of 0 to 1 is taking now the class 1 recommendation. Also, I'd like to confirm here about the use of the GRACE risk score, ischemic risk score, and the bleeding risk score, and to balance between them, despite that the GRACE risk score is downgraded to 2A. And finally, I have to confirm that the guidelines are guidelines, but the act should be balanced between ischemic and bleeding risks in such a very important and critical situation, which is the non-segment elevation acute coronary syndrome. And thank you for your attention.